objectives are that at the end of the talk, you would be able to define concussion and define post-traumatic headache. And you would be able to articulate the differences between something that would be called persistent post-traumatic headache and migraine headache, and then also be able to outline the treatment for post-traumatic headaches, which is really based on the features of the headache. So if headaches have features of migraine about them, we're going to treat them that way. If they have features of cluster headache about them, we're going to treat them in that fashion. So first of all, what is concussion? It's a term that is bandied about quite a bit. There has been a huge amount of interest in the sports world in concussion. Concussion is defined as a change, an alteration in mental status that is caused by injury, and it may or may not involve loss of consciousness. When I was in medical school and the earth was still cooling many years ago, we always thought that to have a concussion, you had to lose consciousness. But we now know that that is not the case. Concussion really is a form of mild traumatic injury to the brain. So the brain is being injured in concussion, and along the time that we were being taught that concussion had to be associated with change in level of consciousness, we were also told that concussion had no long-lasting effects, didn't damage the brain, did not, you could recover from that completely. And now we know that that is, in fact, not the case, that there is actually trauma to the brain. The commonest cause for this is sports injuries. American football, ice hockey, soccer, boxing, and rugby. Combat is another source of significant head trauma. And motor vehicle collisions have become less of a major cause because of seatbelts and because of airbags and things like that. And then lastly, slips and falls that are something that can especially plague us as we get older, and we have balance difficulties, perhaps because we have neuropathy in our feet and don't feel the feet at all. Well, so what are the typical symptoms that people feel acutely after they have had a mild traumatic brain injury? Very often there is confusion and amnesia. So a lot of the concussion screeners ask the player what period it is or what quarter it is in the football game. What round is it? If it's in boxing, what's the name of the opposing team? What's the name of the stadium that they're playing in? Those kinds of things. So higher mental function is affected, and the amnesia is usually for things that have happened just very recently. So, they know their name. They know what month it is. They know what year it is. It's for the more recent events that they can be amnestic. Headache is very common in acute brain injury, and dizziness is also common. Dizziness is a term that neurologists hate because it's a non-specific term. And I typically, when I see a patient, I say, well, let's play a game. Let's pretend the word dizziness has been outlawed, and we have to come up with a different term. And by dizziness, do you mean that the room is spinning? That is vertigo, and vertigo comes from the vestibular system in the brain. So it localizes to certain areas of the brain. Some people, when they use the term dizzy, they mean, the feeling of imbalance, as if they're walking on a floating dock or walking on a waterbed, kind of just feeling a little bit off balance. That too is vestibular in nature in most of the time. And then faintness, a feeling of going to pass out, of going to lose consciousness, that is can be neurological or cardiac in origin and is not related to the vestibular system. And then the fourth choice that we offer them is none of the above. If sometimes the patients have a hard time explaining what they mean by the term dizziness, and you have to dig into it a little bit more. Lack of awareness of surroundings, just being uncertain as to where they are, and nausea and vomiting are also quite common after a mild traumatic injury to the head. Well, the more subacute symptoms, the symptoms that can last for days after a head injury, can be changes to mood. Patients can feel anxious. Patients may feel somewhat depressed, some kind of flat. Some patients describe brain fog, or the sense that everything is a huge effort with their thinking. So I say to people is, yes, it's like swimming in a swimming pool that's been filled with molasses. Just as things are slowed, you have to make a bigger effort for that. Sensitivity to light and to noise are also common, and sleep patterns are often disrupted. Patients may be able to get to sleep, but then they have awakening during the night. They can find it harder to get back to sleep, and poorly restorative sleep often compounds these problems, makes them worse. I'm going to talk a little bit for a minute about migraine. Migraine without aura, the classical type of migraine. 80% of people with migraine have this. And what are the features of migraine? Well, they have a headache that has two of the following. So classically, it's a unilateral headache, but a lot of people with migraine have bilateral headache, and bilateral headache is more common in concussion. Pulsating quality to that headache, and the pain is moderate to severe in intensity. And it's typically aggravated by simple activities. So just a routine physical activity like walking a block or climbing a flight of stairs makes symptoms worse. And that's also something that is noticed in patients with concussions. Some of the work that's done on rehabilitating concussion patients, take them into the gym, have them exercise to a point on a treadmill where they are having symptoms, and then you back the patient off to 80% of that level, and then start with them saying, okay, you can work up to that level, but don't go beyond it. And then when you're comfortable doing that and not getting symptoms, then we can increase that. So you can see that there are a lot of parallels between migraine symptoms and concussion symptoms. And then during the headache, patients can have nausea and or vomiting, phonophobia, photophobia. So once again, quite a bit of overlap with symptoms of migraine. And very often when we as neurologists are asked to see patients to comment on post-traumatic headache, we're trying to sort out, is this a primary headache or is this a secondary headache or is it a bit of both? And by primary headache, what we mean are headaches that begin out of the blue with nothing starting that headache. Nothing triggers it off. They are usually genetic in nature, and this is the classical migraine, tension type headache, and cluster headache would be the most common primary headaches. So they start out of the blue, nothing triggers off the onset of those headaches when they first start. Post-traumatic headaches, by definition, occur after there has been trauma, and so they are a secondary headache. They are secondary to the trauma. But if you're a patient who has underlying migraine, or even if you come from a family who is a bit of a headachy family, migraine runs in the family, and then you have a head injury, you're much more likely to get headaches. And if you already do have headaches yourself, primary headaches, and then you have a head injury, that can make your headache worse. So, what are post-traumatic headaches? Well, they occur in close time block with the known trauma. And they don't have any special characteristic. So even if the patient didn't tell me about the car accident that they were in and the whiplash that they had, or the fall on the ice that caused a concussion. They didn't tell me about that. They just told me the features of their headache. It could sound like migraine. It could sound like tension type headache. Much less commonly, it could sound like cluster. But it's the fact that that headache came for the very first time in close temporal relationship to the trauma that would make it a secondary or post-traumatic headache. So they can also have a marked worsening of the pre-existing headache, and there's very good evidence that trauma does aggravate primary headache, and after people recover from trauma, they typically, as their recovery gets better, their headaches get better, most typically. So um, with secondary headache, the diagnosis is really only definite if the headache resolves or greatly improves after the patient has had some kind of treatment or specific intervention. And unfortunately, that is not the pattern for the typical types of patients that I see. So while we might say 80% of patients are going to get better with their post-traumatic headache, it's going to improve, and they never see the neurologist. They never come in to see the neurologist. There is a subset of patients that have ongoing headache that doesn't improve, and that is the type of headache that causes a lot of disability, prevents people from returning to work, from recovering from their head injury, and can be one of the most debilitating aspects of the concussion. So we can have chronic post-traumatic headache, which is defined as headaches that are lasting more than 3 months. And we can have acute post-traumatic headache, which is in that first 3 months period after a head injury. And there are similar criteria for whiplash. And very often when you have a whiplash as the neck moves forward and then back, the brain is actually rattling inside the skull and getting concussed. So whiplash itself is often associated with concussion. Interestingly, while we have probable categories for tension type headache and probable migraine and things like that, we don't have a probable category for post-traumatic headache. We're required by the definition to say yay or nay on that. So headache is a symptom. It occurs after head injury to the head, the neck, or the brain, and it's frequently accompanied by these other symptoms: dizziness, difficulty in concentration, nervousness, personality changes, insomnia. And that whole constellation of symptoms in the past was known as the post-traumatic syndrome, and now is called persistent symptoms following concussion or head trauma. So persistent symptoms. It's just a bit of, I think that people kind of felt that, oh yeah, you've got the post-traumatic syndrome, had some pejorative features to it, in which it was felt that there was a lot of psychological overlay with that. Interestingly, there have been over the years, there's kind of a seesawing back and forth between some people who said this is all in your head, as in psychological, and to people that have maintained that no, that there are things happening in the brain that are explaining what's going on with this. And for a while, after CT scanners came along and then MRI scanners, when they showed that the brain was entirely normal, that sort of pushed a lot of thinking into the idea, well, that there's got to be a huge psychological component to these symptoms, because look, the scan is normal. back in the 50s, a woman by the name of Sabina Stritch looked at the brains of people who had concussions and looked at it under the electron microscope and showed that little fibers, microscopic fibers, get torn in the brain in people that have had concussions and have recovered from those. But yet you can see the fingerprint of the damage in the brain in people that have had concussion. So she had incontrovertible evidence that there was actually damage that occurred with that. And now, with the very high field strength research MRI scans, we're beginning to be able to show the same kind of thing, fiber tract damage in the brains of patients who have regular diagnostic MRI scans showing them as being normal, but actually showing up with abnormalities. So a variety of pain patterns can develop after you've had a head injury, and they closely resemble the primary headache disorders. Most patients probably have what would be recognized from the description as tension type headache. The headaches are mild, they are bilateral, they don't throb, they're not associated with nausea or vomiting, and they get better fairly quickly. The other 20% of patients, most of them are going to have migraine symptoms, most of which are going to be migraine without aura, some with aura, and a very few patients can have cluster headaches. When the patient tells you that, yeah, I had a headache at the accident site, I had a headache in the emergency department, or I had a headache the next morning, it's pretty easy to link that headache to the trauma that the patient had. A lot of times, though, when patients have headaches, they are looking for an explanation. Why did I have that? And they'll look back in their history and they say, oh, well, I fell off the swing when I was 7 years old. When there's this long time between trauma to the head and headaches, the link between the trauma causing the headache is much, much lower. And it used to be the International Headache Society used to give people a leeway of up to a month, but they had it set at 2 weeks. But now they have lowered the level to a week. The headache should start within a week of either the trauma with the patient being alert in the meantime, or if the patient had a more serious head injury and was in coma or was sedated or given pain medications because they'd fractured their leg and they were on that for a month. And then when that medication was taken away, then they noticed the headaches. Then you can make the link between those. But really late onset post-traumatic headaches, there's been some case reports of things like that, but most of us do not ascribe those headaches to the trauma. We think that there's probably something else going on with them. Some people shouldn't get a head injury or a whiplash because you are going to be more likely to have headaches. So if you're a migraineur, don't take up boxing. This is a bad thing. You will have more headaches. Women are at a higher risk for post-traumatic headache than are men. And that may be related to muscle in the neck and the force that happens in a motor vehicle situation, for instance. And men have somewhat thicker skulls. So there may be some factors like that, but in general, women have more headaches. So they may be, predisposed to develop headache with the same injury, the same, the equivalent injury in a man and the same injury applied to a female would produce headache more likely in the woman, and maybe that's just genetic factors and other things. Mechanical factors such as position of the head. If the head is rotated or inclined, that seems to increase the risk of having trauma after an accident in a motor vehicle collision. And there's this curious dichotomy where the more severe the injury, the less likely you are to have headache. And that sort of played into, for a number of years, played into the idea, oh, well, there's got to be a whole lot of psychological overlay to the patient, because look at these soldiers that have had a bullet go through their head and they're not complaining of headache at all. Whereas, Bob Stewart, who got on the bus and bumped his head on the door as he was getting in, has headaches. And an explanation for that has not been conclusively given. We don't know. There are also some interesting data that suggests that post-traumatic headache is more common in countries that have insurance for road vehicle accidents than in those that don't. On the other hand, there's very good evidence that insurance settlements, settling lawsuits, and things like that don't bring about a cure of your headaches. It's not like going to Lourdes and a miracle suddenly happens and you are cured of your problem when you get a payout for an insurance claim. Most patients do not get better in that circumstance. So litigation doesn't seem to be a big factor. And quite clearly, people that have chronic headache after a trauma often have complex psychological problems going on. We screen all our patients that come to the headache clinic with a screener for anxiety and depression, and there are often very high levels of that. And most of most of us, if suddenly we go from doing everything that we normally did to not being able to do that and having a chronic pain problem, yeah, that's going to cause a little bit of anxiety and depression on our parts. And there's good evidence that treating those psychosocial factors is important, just like treating the organic factors. And I think that most headache experts now feel that it's a combination of things. There are biochemical changes in the brain. There are anatomical changes in the brain. There are things going on in the brain that are very much related to the direct effect of trauma on the brain. And then there are some downstream psychosocial effects that come out of that. So if you have a head injury and you have a headache that lasts for more than 3 months, then you are considered to have persistent headache attributed to mild head injury. And all you have to have is the traumatic event. And the headache has to have developed within 7 days of the injury of the head, or regaining consciousness, or the stopping of medications that impair your ability to report headaches, and it persisted for more than 7 months. For more than 3 months, rather. And what do we mean by mild traumatic injury to the head? Well, it's the patient did not have long-lasting loss of consciousness, so nothing greater than 30 minutes. Interestingly, you can have 20 minutes of loss of consciousness. Most of us would not consider that a mild traumatic injury to your head, but that's the definition. Your Glasgow Coma Scale, which is a measure of your alertness, has not gone below 13 on a scale of 0 to 15, or 3, sorry, 3 to 15. And you don't have post-traumatic amnesia that lasts for greater than 24 hours, and your awareness doesn't last for greater than 24 hours. So those have to be absent to call that mild traumatic injury to the head. And then the transient confusion, disorientation, or impaired consciousness, and the loss of memory, typical concussion symptoms that patients would have after. that. And then some of the other things that we've mentioned already that go along with traumatic injury to the head, concussion. Now, one of the things that happens is in the comment there that they make in the international classification is that you have to look out for medication overuse, because if you use a migraine medication called a triptan, or if you use something like Tylenol number 3, which has acetaminophen, Tylenol, and a narcotic analgesic, codeine, or if you use Tramadol, which is a combination of tramadol, narcotic, and acetaminophen, or if you use ibuprofen, if you use those, if you just use plain, no narcotic, more than 14 days in a month, or if you use narcotic containing medications more than 9 days in a month, they can lead to headache. That can cause headache. And so you need to look at, is the treatment that maybe the patient was taking for their broken arm or their broken leg or their back injury that they had going along with this, could that be contributing to the headache problem that the patient has? Whiplash is another big thing that contributes to a headache. It's this sudden movement, acceleration, deacceleration of the head with flexion and extension of the neck, and it can occur either with really high impact motor vehicle collision at a high speed to low impact kind of things, where somebody's in a pillow fight and gets a bump on the throwing their head back and causing it. So whiplash at the time with neck pain or headache, that has happened, and then 7 days after that, the headache is persistent, more than 3 months, like the head injury, and it's not resolving. And so these persistent headaches attributed to whiplash are often hard to sort out in patients with head injury because the two often go together. So patients often have both of these. The rule when you see these patients is, it doesn't really matter how the injury occurred or what kind of injury they had. What you do is you treat the headache that they have. What are the features of the headache? If it has features of migraine, you treat it one way. If it has features of tension type headache or cluster, you treat it another way. So whether the trauma was a whiplash or a head injury or both, or whether the trauma was a craniotomy that the patient had. And unfortunately, nobody's terribly interested in these types of headaches from the standpoint of the pharmaceutical industry because they are difficult to treat. If you take a patient who has pretty classical migraine headaches after trauma and compare those patients, a group of those patients with fairly classical migraine headaches without any trauma, the ones with the trauma are harder to treat. They respond less well to the medications. They just don't do as well. But what can one do? Well, there are certain physical measures that we can take. We can block nerves. So you can give local anesthetic injections into the scalp, the neck, the muscles in the neck. And I always beg patients, don't ask me how this works, please, because it makes me look stupid. We just know that it seems to work in some people. And I liken it to rebooting your computer. Your computer is acting up and causing you trouble, and you turn it off and turn it on, and lo and behold, the trouble's gone. So it's like breaking up the pain pathway signals for a period of time, 6 hours, as long as the loco would last, and then can that provide benefit? And it does. It does in some patients. And the nice thing about nerve blocks is that it's fully covered by OHIP. So it's not dependent on the patient having supplementary insurance to get this medication to them. Onabotulinum toxin, which has been used now for more than 20 years for treating migraine, does produce an excellent patient response in some patients. In migraine itself, it works in about 70% of patients. About 30% of patients, it's like you've injected water, it just doesn't help at all. probably down more than 40 to 50% in post-traumatic patients, but some get a really excellent response. I find it is particularly helpful if patients have a lot of pain in the neck from whiplash going along with the head injury that they had. That can be helpful. And it's not that it is paralyzing the muscles. Can actually inject it superficially into the skin and not make the muscles weak at all. We don't really want to paralyze muscles. It is has its effect on pain nerves and nerves that release chemicals that cause inflammation on blood vessels. So that's how that works. Patients with headache are seldom rendered headache-free by any of these treatments. If you can get a 50% reduction in the frequency and or severity of your headaches, that would be considered a meaningful response. And the other thing is that typically, injections alone are not going to answer the headache problem. One needs other measures. Sometimes psychological intervention, cognitive behavioral therapy, those kind of things are helpful. And that is something that very often pain clinics and cosmetic clinics that inject Botox don't have the wherewithal to do. So they can do the injections, but they're not there to support the patient in other ways with the other things that they need. So ideally, a more holistic approach would be the one that is most helpful. But once again, psychology treatments cost, and that has to come out of the patient's pocket sometimes if it's not covered by insurance. Counseling can be helpful for some patients. Mindfulness, cognitive behavioral therapy are also helpful. And then there's a whole raft of pharmacology. And so patients need acute treatment. They need something for when they get a headache, can they turn it off? Non-steroidal anti-inflammatory medications work best in males, interestingly. And what you want is something that reliably turns your headache off and renders the patient pain-free within 2 hours. And if you're always taking an NSAID and then having to go to a triptan or a gepant, then you're much better off not taking the NSAID and just going directly to the medication that's the most effective. So the NSAIDs can be used for tension-type headache or migraine. Triptans and gepants are specifically for migraine. And most patients, because of the frequency of their headaches, if they have more than 4 headache days in a month, they're going to require prophylactic medication. And the prophylactic medication, amitriptyline, an old-fashioned antidepressant medication, is the one that has the most evidence that it works in post-traumatic headaches. So it's not our favorite medication. It has side effects. You have to go slowly with the medication, and you have to watch for stimulating appetite, because weight gain can be a problem with this medication. But it generally will be the one that we start with, and we use it at a dose that has no effect on your mood. So it's not being used as a mood improver or anxiety treatment. It's used in too low a dose for that, but it's being used for modulating pain pathways to improve the headaches. And then there are a variety of other medications, from blood pressure medications, anticonvulsant medications, to the new migraine-specific medications, the anti-CGRP monoclonal antibodies and the long-acting gepant, atogepant. So there are things that can be done in the pharmacological world, and very often this is combined with a treatment such as nerve block or Botox injections, and combined with psychological support for patients as well. Sometimes physiotherapy or chiropractic manipulation for the neck as a physical measure. All of those things can be done together. Post-traumatic headache in patients with pre-existing headache. I've mentioned this before. Individuals pre-existing headache or particular risk for post-traumatic headache. Generally, best to avoid situations in which concussion is common because of that. And I kid my patients that I say to them, we're not ready to have you book your flight to France yet. And that's to say, in France, they have this little machine that severs the head from the body, and that always cures headaches. But the process of treating post-traumatic headache is a frustrating one for both the physician and for the patient. It takes a long time. All these medications that I've been talking about, some of them take 2 months to get them up on the proper dose, and then you have to take it for 2 months to know whether it's going to work or not. Some of them require 6 months of treatment. So it is a real process, and one of our jobs as physicians is to encourage our patients that, don't give up hope. There's other things that we haven't tried that we need to go through with you to help you with your headaches before we have you book your flight to France.